I'd like to welcome you to the Fairbanks Ethics Lecture Series. My name is Paul Helfton. I'm the director of the Charles Warren Fairbanks Center for Medical Ethics. We've been conducting this lecture series for more than 7 years now, and I just have a few brief announcements, and then I'll introduce our speaker. Please silence all of your cell phones and pagers. If you need to return a call, you can just step out to do so. This lecture is also being broadcast across campus to the Riley ROC Auditorium, to IU Health North, Arnett, and Ball Memorial Hospital. And I'd also like to give a special thanks to Amy Chamness, our program coordinator, who really takes charge of this meeting. It's my great pleasure to introduce my colleague, Dr. Mary Ott. And I wanted to introduce her by saying that she's an all-around awesome person, but I figured that wasn't quite formal enough, so I'm going to give you a little more of the formal introduction. So she is an Associate Professor of Pediatrics in the Section of Adolescent Medicine, the Department of Pediatrics here at the School of Medicine. She got her undergraduate degree from Princeton University, or MD from the University of Pennsylvania, and a master's in Philosophy and Bioethics from the Indiana University, Purdue University at Indianapolis. She completed her residency in pediatrics and her fellowship in adolescent medicine, both at the University of California, San Francisco. She's board certified in pediatrics and adolescent medicine, and at Riley Hospital for Children in Indianapolis Community Health Center, she provides general adolescent care, adolescent sexual and reproductive health care, and ethics consultation. I could go through a long litany of her accomplishments, publications, and otherwise, but I'm going to leave those for now and just tell you that her research focuses broadly on adolescent pregnancy and STI prevention and ethical issues related to vulnerable populations and sensitive topics. So it's my great pleasure to introduce Mary Ott to you. Thanks.
Thanks, Paul, and thanks to the Fairbanks Center. So, as Paul had said, I'm an adolescent medicine physician, and I have expertise in pediatric ethics. And while my work primarily focuses on STI pregnancy prevention, I do a lot of work with vulnerable populations on sensitive issues, and this has led me to the issue of adolescents' capacity to consent in treatment and research situations. My perspective today will be that of a clinician and a behavioral researcher, so not a neuroscientist. And my work tends to be highly applied to clinical work and research. The focus will be a little bit more on research because that's where my recent studies have been. I feel like I can't, so here's our learning objectives. I'd like people to know the components of capacity to consent, ways to assess capacity, to justify adolescent-informed consent using developmental and ethical arguments. I'd like people to be able to identify individual and situational characteristics that influence capacity, and to be able to design clinical and research procedures to support adolescent capacity to consent. And I feel like you can't do a lecture on adolescent capacity without talking about adolescence in general. It's a time that's an intense time of transition from childhood to a sexually mature adult. There are physical changes, social changes, psychological changes, and cognitive changes. And just to illustrate some of these, to give you a background on capacity. So the first is, so adolescence is a time where kids move from being a child to being adult. Everybody goes through puberty, but they all go through puberty with different timing. And so this is a picture of Ben Davis's freshman basketball team. So these are all 14 and 15-year-old boys. You wouldn't know that from looking at it. A couple of the boys in the front row look like they could be in middle school. A couple of the boys on the back row look like some of the young adults I run into on IUPUI's campus. So it's a time, so this change, these physical changes are different. Everybody has different timing. And it's important to keep this in mind as we work with teens. Socially, adolescents are increasingly independent, self-sufficient, and responsible. They move from families into peer groups. Adolescents are immersed in a world of cliques and crowds and best friends. And it's also a time where they transition from childhood and grade school to higher education and the workforce. So they have really important role transitions that they're preparing for. these social changes map onto psychological changes, and the core task of adolescence is identity development. And what we see a lot are young people trying on different roles, and it's they go through a process of exploring their own values, ethics, ethnicity, sexuality, and gender. And there's a real tension there when you meet with young people, learning, and they're in the process of learning what makes them unique versus a need to fit in with other kids. And and you can see this pops up in funny places. I surveyed kids in 2 different high schools that had similar ethnic mixes, but when the kids self-identified their ethnicity on the survey, one of the high schools had a much broader range where kids would list Irish American and Arabic American versus the other high school. So this idea of thinking about what makes them a person trying on the roles and what makes them unique is important. There are also increasing academic demands of adolescence, which leads us into cognition. What you have here is Algebra 1 versus calculus, so thinking about 7th to 8th grade versus seniors in high school. Oops, I'm going to go back. The other thing that you notice during this time of adolescence is, the textbooks get bigger. Kids need to cover much more organization. They need higher level executive organizational skills. They need increasing ability to abstract. If you just look on this side going from algebra to calculus. So all of these cognitive changes happen. And so, what we see cognitively is an increasing ability for future orientation, thinking abstractly. Kids are able to simultaneously consider multiple options and consequences. They have, like I said, manipulate abstract information and have improved impulse control. And so what I'm going to do is expand this idea of cognition and assessment of cognition. As I said in the first slide, none of these changes happen at the same time. Adolescent development is dysynchronous. We see physical changes first. Girls get their period at 12 and a half, are done by 14. Cognitive changes follow. If you think about high school ages, 14 to 18, where a lot of these changes are happening. And psychosocial development, where they move into peer groups and have role transitions, happen even later. So I want to talk a little bit about legal capacity to consent, because it sets the stage for understanding why we need to assess capacity, why we need to assess cognitive capacity to consent. So with adults, we presume them to be competent. With young children, we presume them to be incompetent. In adolescence, there's really a question mark there. But it turns out that, from a legal perspective, adolescents below the age of 18, can consent to certain services. So what we have in Indiana is 18 is our age of majority. If they're less than 18, they can't consent to general care. If they're 18 or over, they can. There are exceptions to this below 18 rule if they're emancipated by court order, if they're married, and we're seeing increasing numbers of married minors as we get immigration from Southeast Asia and South and Central America. Minors in the military service are allowed to consent to their own care. So there are certain classes of minors that can consent to care, but there are also certain services for which minors can consent for. So Indiana state law, which is our strongest support for adolescent consent, allows adolescents to consent for STD-related services, substance use, and while parental consent is required for abortion, there's a judicial bypass that's possible. Other areas of sensitive services are covered by federal case law and statutes. So, for instance, contraception, sexual assault, outpatient mental health, and additional supports for substance and drug use. So there are situations in which minor adolescents can consent. These situations are often on sensitive topics. So we're thinking about issues related to minor self-consent in many of these situations. Research regulations, well, research is different than clinical care. It turns out that the research regulations explicitly reference jurisdictional regulations in terms of ability to consent to research. So kids from a research perspective are defined as children if they cannot consent in their jurisdiction. So for instance, in my work on STD prevention in teens, kids are able to self-consent for research studies. So it's really important for us to understand sort of capacity to consent in this sort of legal environment. So a word about HIPAA, because I can't give an adolescent talk on consent without bringing it up. It turns out like HIPAA, while we typically think about it as restricting our ability to have adolescents consent for care or have confidentiality, it actually supports it. So HIPAA itself allows parents access to the records as the personal representative of the minor, but it turns out that this access is denied if the minor can consent under state or other laws, or if the parent agrees that the minor may have confidential care. And so these are important exceptions to HIPAA in areas where we might have adolescents providing self-consent. I know that in my clinic, I will talk to an adolescent and parent about consent yearly at every well check, and then at visits on about sensitive topics, so that the parents and I can come to an agreement about what information is confidential and what isn't. The other thing that HIPAA states is that if the law is silent, provider discretion rules. So again, this gives us some flexibility and increases the importance of understanding minor consent, capacity to consent. So this is a little bit of a sidebar. This is a slide adapted by work by Lexi Torkey, but I like to bring it up because I think it's important to understand like sort of how we treat teens versus how we treat adults with respect to consent. So if you look at the triangle, at the first triangle, this is child and adolescent consent. And what we have is when they're little, parents consent from like, you know, sort of in middle childhood through adolescence, you have parental permission and participant assent. And this is a time of evolving capacity, and it's only at the legal age of majority, so 18, that adolescents for general care can give their own informed consent. But their capacity to consent actually happens much earlier. In the adults, in contrast, on the other side, if you look at the blue, the adults can consent for quite a long time and can go through a period of diminishing capacity. And it's only when they're judged to lack decisional capacity do you involve surrogate consent and participant assent. So there's a real disparity in terms of how we deal with young people and how we deal with adults. So this is my new favorite slide, and this is we're going to get into a little bit into the meat of the talk. And I think it sort of gets at this idea of how adolescents think. And I live in a really old house, and I certainly have some mice that are able to set off the traps and get away with it, and other mice that get caught in the traps. But I think it's like, so teenagers think a little bit differently than we do. And this is, although I'm not a neuroscientist, I'm going to evoke some of the work of my neuroscience colleagues because I think it helps us understand issues around capacity. So what this diagram is a map of the human brain, and this is density of neurons in gray matter. And the warm colors, the reds and yellows, are higher density. And the cool colors, the blues and the purples, are lower density. And what happens across adolescence is there's, in the gray matter, there's a lot of pruning of synapses. And so synapses that get used are sort of retained, things that are used are sort of retained, and things that aren't used are pruned out. And this is, simultaneously, there's myelination, which isn't in this slide, which increases the efficiency of connections within the brain. So the combination of the two of these gives you sort of increasing efficiency in how individuals think, and increasing capacity. So the other thing that happens, also not in this slide, but that the brain, like the rest of sort of development, all the parts don't develop at exactly the same time. And what we see is that the control of senses and emotions develops first, and then like sort of planning skills and impulse control, sort of the frontal lobe stuff, develops a little bit later. So there's a little bit of dyssynchrony in adolescent development. And the original title of this slide, suggested by a teen, was different, not stupid, instead of different, not deficient. And I like to bring it up because we have this sort of view of adolescents as these sort of wild beings without a frontal lobe. But it turns, and they do have, their frontal lobe is different, I'll give you that. But I think that this is like an adaptation. And it's really important to think about it as an adaptive, as sort of a different adaptation. This is sort of this slide. I'd like to take an evolutionary look at this. So if you think evolutionarily, and I don't think that's a word, but risk-taking is really important to learning. We are most efficient at learning when we take risks and we either mess up and don't do well, or we take a risk and we're successful at it. So, adolescence, if you think of from an evolutionary perspective, is a really important time for learning. And so this brain is sort of highly adapted to learning. I mean, if you don't take risks, you don't learn. And the process of risk-taking allows individuals to sort of assess their own capacity and their own limitations. So it's a really important piece of our lives, and it's a really important adaptation. Here we go. So no, hot and cold is next. So I'd like to talk so that, and I have to say, like, this risk-taking, as a physician who takes care of kids, we're sort of primed to think about risk as bad and risk as something that's really negative. But I'd like you to sort of challenge you to think about risk as sort of a beneficial thing, and we'll get to that on the next slide. The other sort of take on adolescent brain development is this issue around hot and cold decision making. And hot and cold decision making has become really popular. So a cold decision making is a decision that occurs in a controlled situation. There's not time pressure. There's low emotions. And when you look at cold decision-making situations, adolescents make decisions similar to adults. A hot decision-making situation is when there's high emotion and distraction. And in hot decision-making situations, adolescents have different types of responses and frequently make riskier decisions or make less careful decisions. And so a neuroscience colleague of mine did a driving simulation with teens and adults. And like when the kid was in the room by themselves in the driving situation, all the decisions the teens made in the driving situation were quite similar to those of adults. But he just put a couple peers in the room with the teen, and the peers weren't even that distracting. They were just sort of talking to the kid the way they would in a car. And these kids in the driving situations tend to make much riskier driving decisions just with the peers around with that level of distraction. So there were differences in adolescent decision making in these hot situations. And I think it's an important thing to think about, these sort of this situational effect. So is willingness to take risk all bad? And I really want to question that because, like I said, as a physician, we're sort of, in healthcare providers, we're primed to think about risk as bad. But risk is just a situation where there's a potential for gain with a possibility of failure. And certainly a lot of the risks are unhealthy. So tobacco is unhealthy in any situation. Stealing, self-mutilation, running away, all of these are unhealthy risks. But I'd like to challenge people to think about the possibility of healthy risks. So trying out for a sports team, public speaking, having a boyfriend or girlfriend, asking someone out to the prom, standing up to a bully, raising your hand in math class when you're not sure but maybe sure you know the answer. All of these are healthy risks that help young people learn. And it's the fact that their brain is sort of hardwired to allow them to take these risks that allow them to move forward and learn. So I'm going to shift a little bit to decision-making capacity. So we're going to shift out of sort of neuroscience and brain wiring and into behavior. And I have one sort of caveat for my lawyerly colleagues there. So I'm talking about capacity and not competence. Competence is a legal concept. It's sort of mental soundness necessary to make decisions about a specific issue. Capacity is more of a clinical concept. It's the ability to make an informed decision. If you're thinking about a capacity assessment in a treatment situation, any licensed physician can make a capacity determination. So what I'm going to talk about right now is capacity. So capacity broadly is sort of this ability to appreciate the risks and benefits of situations and make reasoned choices. And we typically think about 4 components of capacity. The first component is understanding the information. So you need to understand the risks, the benefits, the purpose of the treatment or the purpose of the research program, what your alternatives are, and what the procedures will involve, so what the actual treatment or what the research study involved. The second piece is appreciating your own situation, sort of like understanding your sort of either medical situation or social situation, such that you can apply this information to yourself and think forward about like how this might affect you. Thinking about whether this is treatment or research in the case of research studies, and understanding that if it's research there may be limitations. The third thing is to be able to logically manipulate the information, to be able to consider the risks and benefits, to be able to consider what would happen if you participated, what would happen if you didn't participate, what would happen if you chose different treatment options. And the fourth is the ability to express a voluntary choice. So these are the elements that we typically think about in terms of clinical and research decision-making capacity. It's also important to remember that capacity is decision-specific and somewhat risk-relative. So I would hold an adolescent to a higher capacity to make a complex treatment decision, like decisions about radiation versus chemotherapy for cancer, clinical trials research where you might be trying out a new medication might take a higher level of capacity. Lower capacity decisions would be things like routine screening tests for STDs or diabetes where there's not really harm and it's an established benefit. Routine or low risk, other low risk treatment decisions, and minimal risk research, so research with surveys, with non-invasive screening approaches. Life experience is also really important in capacity assessment and can influence capacity on multiple levels. So those of us who work with people making treatment decisions, it's pretty clear that previous experience with medical treatment or research procedures allows us a more accurate assessment of what's going on. For those of us who do ethics consultations, having a teenager who has a recurrent leukemia and is saying that they really don't want to pursue therapy, you might give more weight to that young person's thinking because they've already had experience with it. They know what it's like to be hospitalized. They know what the treatments include. They know what chemotherapy feels like when you receive it. So this idea of previous experience is really important. And when we look at behavioral research in adolescents, we see a bidirectional relationship with their sort of risk perception and cognition in experience. So their perceptions of risk and decision making influence their behavior, but also behavioral experience will influence their risk perception and cognition about and decision making. Emotion is a piece of decision making that people typically don't talk about, but I think it's really important to talk about it with teens because of issues around brain development. And so what we find with teens is that emotion does influence decision making, probably the same with adults, but I'm just familiar with the teen literature. So a psychiatrist that's looked at adolescents' capacity to stand trial found that measures of psychological maturity, so their risk appraisal, their future orientation, and their susceptibility to peer influence affected their capacity assessment. One of my colleagues here, Matt Alsma's group, has looked a lot at emotional dysregulation in young people and found that anger and emotional dysregulation influence decision-making about risk behavior. So we know that emotion influences decision-making. It's sort of similar to the neuroscience research that I talked about with hot and cold situations. So there's not a lot of data on adolescents' capacity to provide a more informed consent, either in research or in treatment settings. I mean, what I've talked about is sort of abstracting general principles of adolescent cognition and cognitive development to the question of capacity to provide consent, but not a lot of people have specifically looked at their capacity to provide consent, and it's something that needs to be, again, decision specific. You need to do it across a wide range of ages. It's something that is not easy to do. There was sort of a landmark study in the early 80s where they took children from like early elementary grades up through young adults, and they found that adolescents from about 14 on were understood and processed health information in a manner similar to adults. So what they did was they did a simulated or like a simulated type of consent clinical situation, and they assessed their decision making around it. Younger adolescents, 9 to 13 years old, were able to understand risks and benefits, but they were less able to consider multiple conflicting viewpoints and multiple options. But in the end, their final decisions were actually similar to adults. And finally, very young children were capable of a basic understanding of research procedures. So this is really sort of somewhat different than the way we treat kids. Like, we oftentimes don't do anything at all with very young children. And this sort of like the tweens and school-age kids are often not involved in decision making. There was just an ethics consult about a 10-year-old, and the team had not yet sort of assessed the 10-year-old's take on the clinical decision-making issue. And it's reassuring that in this sort of cold, rational decision-making situation, adolescents made decisions very similar to adults, and it's sort of consistent with our understanding. So there's less data on adolescents' capacity to provide consent to research. And I'm going to switch a little bit to research because that's where my work is done. Sort of the gold standard is a formal psychiatric interview, which is lengthy and requires a trained person. And then they have a number of capacity assessment tools that are available to use with adults. I like the MacArthur Competency Assessment Tool, which has been adapted for research, treatment, and criminal adjudication, or figuring out whether someone needs to stand trial, because it assesses all 4 of the domains we talked about earlier. It assesses understanding, appreciation of one's own situation, reasoning, and voluntary choice. There are also a number of short tools out there that are used primarily in research situations. And they generally assess understanding and maybe some appreciation of their own situation. One is called the Evaluation to Sign Consent, or the ESC, and the other one is called the UCSD Brief Assessment of Consent to Capacity, which is actually sort of a shortened form of the understanding and appreciation subscales of the MacArthur Competency Assessment Tool. So there are tools out there. None of these, other than formal psychiatric interview, have really been validated in teen populations, although there's a little bit of use with teens. And these are the sort of the domains assessed to give this idea of what we're assessing when we use them. So the formal psychiatric interview and the MacArthur, the MAC-CAT, assess across all 4 domains. The shorter tools will assess 1 or 2 domains. So the MAC-CAT has been used a little bit in adolescents. So there was a small study of adolescents who were hospitalized with anorexia and compared to healthy controls. And they found that while both groups had sort of similar understanding of risks and benefits and treatment procedures, the healthy controls had better reasoning skills. And so this is actually reassuring to me in terms of our understanding of adolescent development and cognition, because the severe malnutrition that we would see in a hospitalized young woman with anorexia would certainly cause like sort of cognitive slowing and decreased cognitive capacity. So it sort of makes sense with what we know, and it sort of is consistent with our understanding. The MAC-CAT for clinical research was piloted across a wide range of kids, 7 to 15-year-olds with ADHD and oppositional defiant disorder. and their parents in preparation for a medication trial. And what they found was that both children and parents had a good understanding of the trial procedures, but the children had difficulty with abstract concepts like placebo. And they found that kids who were very fearful of disease worsening or had a poor relationship with their parents scored lower on the MAC-CAT-CR. Now, these data are really interesting, but they're primarily childhood data. There was only 20 kids, there was less than 20 kids in the sample, and the mean age was around 10 or 11 years of age. So it's really an assessment of younger kids' decision-making skills. So this sort of brought me to my study, and so what I did was I have to sort of give a shout out to the IU Center for Bioethics for providing seed money for this, and the Society for Pediatric Research for providing a summer student. But what I did was I looked at healthy teens' capacity to consent to research, and we called the study the Thinker Study. And the purpose was to take these adult capacity assessment tools and adapt them for use with adolescents, to look at adolescents' capacity to consent to research, then to describe the capacity to consent to different types of research studies among adolescents in a community sample, and finally to look at factors that influenced capacity to consent. And although these are preliminary results, so we've only analyzed 30 participants, the data are really instructive, and we found fairly strong effects. So it was the first thing I did was start with a community-based volunteer sample with a range of ages that passed from kids that were legally minors to kids that had the legal capacity to consent. And we got a range of life experiences. So we recruited them from like Medicaid clinic populations and IUPUI undergrads and kids in school settings and kids. This goes across a variety of different community settings. The kids did a simulated consent process for 3 different studies. So we sort of sat down and said, what types of research do healthy children get involved in, and what do we want to understand? So we started with an STD screening study, which is really like a public health minimal risk screening study. It was for boys. They did a urine sample and took a survey. The next study was the Indiana Biobank study, and so individuals provide a biologic sample, usually blood, sometimes buccal mucosa or other types of biologic samples that are obtained in clinical care to be banked and to be used in the future for genetic studies. And the final was a randomized control of a new headache medication. The first 2 studies we used actual study consent forms and consent processes for it. So the Indiana Biobank study is a study that recruits teens. My STD screening study was a teen-specific study. I wasn't able to get a consent form from a pharmaceutical company for the randomized controlled trial, so I just sort of I had a really creative RA who just sort of dumped in information into the standard consent forms and consent processes for pharmaceutical studies. And then each kid took a MAC-CAT-CR for each of the 3 simulated consents. So we had one for STDs, one for biobanking, and one for the headache medication. They completed the REALM, which is a measure of adult literacy, and has been validated in teens. And then we had demographic information, and a particular interest with this was age and a measure of family affluence. You can't look at income with teens because oftentimes they don't have access to that kind of data. But there are some established, validated family affluence scales that we can look at that look at like having your own bedroom, how many cars your family owns, how many computers your family owns. That sort of tracks well with family income. So the MAC-CAT-CR itself hits these 4 domains: understanding, appreciation, reasoning, and choice. The understanding domain is the biggest one, where there's 10 to 13 questions, depending on whether there's actually a treatment decision in the study or not. And again, covers purposes, risks, benefits, and procedures. Appreciation is 4 questions. You look at whether the adolescent would personally benefit. Reasoning is 3 questions where they explain their reasons for participating or not. And choice is 1 question where, do they recognize that they don't have to participate and that it's voluntary. So here's an example of some of the questions, and I'm not going to try to make you read this, but if you just look at, look at understanding and look at the first question. So the MACCAT starts broad and gets narrow. So can you tell me your understanding of what I just said? This is done when they finish describing research procedures and the purpose of the study. And then if the person doesn't tell you what the purpose of the study is, you can ask them what the purpose of the research project is and specifics about it. How long will it last? What sorts of things will people have to do if they agree to be in the study? The MACCAT is then scored, and again, this is hard to read, but I just uploaded one of our score sheets. So, like for the score sheet for the headache medication study, understanding the nature of the product required to get 2 points. They had to say that it tests safety of the medicine and test how well the medication worked, and they had to say both for their 2 points. They had to say that it'll last for 12 weeks, that it'll include a blood draw, and that they would need to take the medications and fill out pain charts, one point each for those 2 things. So this is an example of how you might score this. So it's a very subjective type of scoring. We're actually having 3 people score each of these and sort of look at interrelator reliability. And then we ended up adapting the tools for adolescents. And so what we first did was we bought the book for the MACCAT CR, and we followed the book exactly. And the book tells you to do your whole consent process and then go back and summarize each section and then ask the questions. And it was a real disaster when we did it exactly the way they wanted us to do it for adults. And when we sat and thought about it, there are really different cognitive issues in adults with impaired capacity to consent versus adolescents. So adults with impaired capacity have capacity impairment that's related to disease. Dementia, severe mental illness, schizophrenia, severe depression. When they look at clinical samples of individuals, outpatient samples, community samples of individuals with mental illness, they tend to make, have decision-making capacity similar to healthy controls, but an inpatient up to 30% can have limited decision-making capacity. So it's like really a different, so it's very disease-related. The types of things in adult capacity that cause problems are memory, cognitive slowing, for schizophrenia being grounded in reality. And these are really different types of issues that you see with adolescents and evolving capacity. I mean, adolescents, we're looking at a normal developmental situation. There are issues around emotion and distraction, issues around risk-taking, around inexperience. The types of diseases that adolescents have are actually fairly different than the kind of diseases that adults have. Schizophrenia appears during adolescence, but we don't have as many really severe schizophrenics. So when we thought about it, the cognitive issues were quite different. So we started to adapt it. The first thing that we adapted is the MACCAT CR is written, has a lot of repetition of information, which makes sense when you think about adults with waning capacity and dementia who have memory problems. But the adolescents found this absolutely excruciating. Like they're like, please don't ask us again. So we reorganized the entire interview with decreased repetition. So instead of doing the whole consent process and then repeating pieces of it and asking them questions, we integrated the questions into the consent process, so they only got the information once. The other thing that the RAs started to do is they warned the adolescents that there would be a lot of repetition, so they could sort of steel themselves for it and be ready. I mean, when has an adolescent had a memory problem? I mean, when does a younger child have a memory problem? So it's really like this tool that was really designed for sort of a different type of problem. The other thing we found was that remembering, which they do really well, was not the same as understanding. And adolescents are really good about, the concept of placebo would come up, but they could say the word placebo, but they may or may not have understood exactly what a placebo was. So it required some additional probing. So we started training interviewers to say, what do you mean by that when they gave a research concept like that? And then the last thing was this issue of sort of appreciating your own situation and making a voluntary choice it's really important in the MACCAT to understand issues around sort of personal benefit and not getting issues or a non-personal benefit. In adolescence is a time where there's a fair amount of egocentrism just because they don't have a lot of life experiences. So there oftentimes we saw patterns of more egocentric answers. But the other thing that we saw was that adolescents are also an extremely altruistic group. So if you look, like, there's not a high school in the city that doesn't have a requirement for community service, because this is really good for youth development. Kids love it. And so they put a lot of weight in their decision making on helping others, which was really interesting. So there were these sort of tensions and these types of answers that were different. So here's our study participants. We have 30 who are analyzed, mostly female, about half white, and half youth of color. This family affluence score, the FAS, there was 5.8, and so if you think, like, what it turns out is like 6 to 9 is high affluence, 3 to 6 is medium affluence, and 1 to 3 is low affluence. So they're sort of in the middle affluence group at the upper end of it, which probably fits with our Indianapolis community. The REALM score is a score for health literacy. It's an adult health literacy score. So their mean score was 61, which is sort of at the lower end of good health literacy in adults. So sort of areas that I would expect it to be based on sort of our mean age of 17. And so this study, I'm just going to point out a couple little things on this. So the first, these are our scores. And so what we have is a score and plus or minus the standard deviation for the headache study, the biobank study, and the STD screening study. And then we have their sub-scores: understanding, appreciation, reasoning, and choice. And the things I want to point out is that the scores are in an okay range, which suggests that kids are making decent decisions. They have like decent understanding. So the headache study was about 21 out of a max of 26. The biobanking and STD study were about 16 out of 20, which is an okay score range. There's not a threshold for teens, and remember, these are sort of study-specific scores, so the investigator needs to determine the threshold. So there's not a like you're above this number and you're competent, below this number you're not. It's sort of a continuous scale. Appreciation scores were like around 5 out of 6, so understanding their own situation. Reasoning scores were 6 out of 8. So all of these, like, it wasn't perfect reasoning, but it was, certainly fairly decent reasoning. And there was no problems expressing a choice for any kid whatsoever. Every single one of them could express their own choice. And we looked at this evaluation to sign consent, which is a short form, and when we compared it to the understanding subscale, we found that the scores were relatively similar. So they're getting like 6 to 8 out of 10, as opposed to 16 out of 20 or 20 out of 26. So they sort of tracked together. This is sort of what I find is sort of the meat of this pilot study, and the most interesting piece is that we found really strong effects for family affluence and health literacy on capacity to consent. Even in a sample size of 30, we found significant effects. So I'm going to walk you through this regression. The first, we did 3 different analyses, one for understanding, one for appreciation, one for reasoning. The first thing we did was look at the effect of age, then we looked at the effect of family affluence, and then we looked at the effect of health literacy. If you look over at the back end here, our p-value is sort of significance, and with a group of 30, you have to have a pretty strong effect to have a significance. And then the other thing to look at is the standardized beta, which sort of weights the absolute effect of these. So age, affluence, and health literacy have pretty similar standardized betas. And so what this means is that age is a big predictor of capacity to consent, but equally important is family affluence. And I think that this probably works through exposure. Kids from increasingly affluent families have different types of life exposures. There's more vocabulary that they get exposed to. There's more different types of life, sort of vacation and travel and things like that. And then health literacy, sort of controlling for age and controlling for affluence. Health literacy had an independent effect that was as strong as age and affluence. So these are really, so among sort of older affluent kids, their health literacy determined their understanding. It makes sense. And we saw similar effects for appreciation and similar for reasoning. So I thought it was, we typically think about consent as a function of age, and all of our sort of regulations around consent are set up as a function of age, but it really makes you think about considering consent as not just a function of age, but a function of sort of what types of life situations the young people are in and what they bring to the table in terms of issues related to literacy and cognition. So the second study, we looked at research decision-making processes, and this was done in a simulated HIV vaccine trial. It was a network study that I did with one of my colleagues, Greg Zimmett, in the Adolescent Medicine Trials Network for HIV/AIDS interventions. There's 15 sites around the country in areas where there's high prevalence of adolescent HIV infection. And they have like a research site, and so we had kids at 4 different research sites participating in this study. The larger study was looking at the effect of consent materials on something called preventive misconception. And during a simulated HIV vaccine trial, there hasn't been an HIV vaccine trial in kids. There have been a lot in adults, but we have to wait until the adult vaccines are effective before we start trying them out in kids. So it was a simulated trial where we took the adult consent forms and processes and adapted them for younger people. I was able to interview 33 young people, and the requirements was that they were kids that have sex with men or at high risk for HIV. It was about half young men who have sex with men and half high-risk females. They went through the consent process, and then they did a debriefing interview on what they understood about research concepts and the process of research decision-making. So these were in-depth interviews. We trained people at all the 4 sites. So what we found is that their decision-making process mapped really nicely onto the relevant domains of research decision-making. Like kids talked about the purpose of the study, were able to name risks and benefits and talk about trial procedures. They talked about their own situation, whether it was research or treatment and personal benefit. They were able to reason about their options. They weighed the risks and benefits. They also did things that were more specific to teens, like they all talked about discussing participation with others, and the last thing we did was sort of look at motivations. And finally, they were all able to express a choice. So it mapped nicely onto this adult decision-making model with some adaptations for kids, and I'm going to go over some of those adaptations. So the first is this idea of appreciating their own situation. And so one of the things we find, so these are kids at very high risk for HIV, is stigma was an enormous concern for these high-risk kids. And these kids, it was stigmatizing for them to even consider to participate in a vaccine trial was stigmatizing. So a kid said if your information got leaked that you were in the study, somebody might assume you have HIV. So it's possible you can lose a job, or your family could. I don't know how to put it, but your family might not agree with it, or they might treat you different as far as thinking that you have something. So this was a big piece, like understanding like they were in a very vulnerable situation. The stigma might differentially affect them as young people. They were sort of dependent on family. The other piece was discussing participation with others. So kids talked about consulting with trusted adults. Mostly young women would consult with their mothers. She said she's a big part of my life, she's a big influence, and if she were to tell me no, I'd listen to her and see why she's saying no, and if it's for some of the same reasons, then I probably wouldn't. So young people are embedded in families more so than adults, and so thinking about this situational influence is really important when you're thinking about consent for them and capacity. Other kids talked about doctors and thinking about medical they're healthcare professionals. This kid said a doctor is a big one because of his status and his being educated. I think he could speak more off of the facts instead of what he thinks. I think by telling him the information that was provided to me and then knowing his background information from his personal experience, that would help me with my decision a little bit more. So these kids were really like consulting outsiders, and that was an important part of their research decision making. And I think as we work with kids thinking about that, if they can't involve a parent, is there another trusted adult that we can work with? The final area that came out that was sort of different for kids was this issue of motivations and sort of what drew them. Monetary compensation was really important. I mean, and I think a big piece of that is there's not a lot of jobs open to kids, particularly kids in high-risk situations. So this is like a lot of them consider this sort of as a way to legally earn money. Access to the vaccine was important to them. They knew that it was research, but they also knew that they were high risk and there's not a lot of other prevention options available to teens. And altruism, and we talked about altruism before. This kid says, I think the benefits are HIV is global, a big problem. I think we need to step towards a vaccine. I think it's globally benefiting, not just benefiting me. They like to feel part of something bigger than themselves, and curiosity and learning were important. So these are really developmentally specific motivations. The last piece of our analysis was looking at, sort of cognitive tasks and what they needed to do for a vaccine trial. And so we looked at, did they understand vaccine? Did they understand placebo? Did they understand the concept of experiment, the concept of randomization? And then did they acknowledge that they would need to have safer sex behaviors despite having a vaccine? And so what we found across these is that mostly they understood vaccine, placebo, experiment, and mostly they acknowledged the need for safer sex behaviors. The one area teens had a lot of problem with was their understanding of randomization. Some kids thought they would get the vaccine because they were lucky. Some kids thought they would get the vaccine because they usually get chosen for that type of thing. So this idea of randomization was really difficult. It may not be a teen-specific issue. When I've looked at adult studies of numeracy, I've found like equally abysmal results among American adults. So this may be sort of a global issue. But the thing that was really important and I felt was developmentally specific was that when we walked the kids through, when they did during this debriefing interview, they did a lot of active processing during the interview. And so they would talk it out with themselves. Like the one kid initially thought the vaccine was curative, and then as he sort of thought about the study and the procedures and what was doing, he corrected himself later on. Other kids would talk it out with the interviewer. They would develop ideas as the interviewer repeated questions or asked probes about the questions. So kids that might not have initially thought much about the idea of experiment when they were asking about, did they think that the vaccine would work? They said, oh yeah, no, this is a study. It's not going to work. So they sort of developed the ideas in the process of talking it out. Some kids would correct themselves later on, usually after going through step 1 and step 2. Other kids might restate what was on the consent form with a fair amount of confidence, remember the memory issue. But as they talked about it, they would realize that there was nuance to it. And then finally, they would feel things out with the interviewer. Like if they were talking about risks and benefits, they would be like, well, I think that some of the risks are blah, blah, blah. And one kid actually turned the interview around and started interviewing the interviewer about the study during the debriefing interview, feeling that they didn't get enough information during the informed consent process. And I felt like this active processing piece where the kids were sort of like actively thinking about information was very important to our sort of working with kids and thinking about what they need and supporting their capacity to consent. So in summary, based on my work, it felt like most adolescents had capacity. They may be more vulnerable to situational influences, and then there may be ways that we can support them through careful consent processes. And I think supporting adolescent capacity has to first start with attention to circumstances and environment. Is there distraction? Is there emotion? Is there urgency? Do they have previous experiences in these areas? Is it something where you're working with high-risk teens on a really stigmatized topic where issues around sort of stigma and shame might come into play that we need to think through? Attending to factors that can influence capacity other than age. So, we looked at things like health literacy and family affluence and different types of life exposure, education. thinking about consent as a process, this sort of active processing for teens, so you can assess understanding and decision making during the consent process. I know that many of my adult colleagues talk about a teach back method with adults with impaired capacity, sort of assessing where they're at and then correcting any misperceptions, and then encouraging adolescents to consult with trusted adults. There may be situations like an STD or HIV prevention where it's not safe for the young person to consult with their parents, but there may be other adults in their lives that they can consult with. It may be that the study themselves or the clinic can offer someone that they know and trust and can work with. And that's it. Thank you for your attention. Are there questions? I'll take questions individually if there are any for the group. Thanks. Oh, there's a question in the back. Yes. Well, so I don't think you can assume all consents are cold, because there are people that can get consented around really emotional circumstances. So thinking about research in the emergency department, even simple, like I have an adolescent colleague who does STD research in the ER, and you have kids coming in who may or may have a parent outside the room who, she'd like to enroll them in this STD screening or treatment study. So that might be an example of like a high emotion. They're worried about whether or not they've got something. They've got a parent there. I mean, there's sort of obvious medical, like sort of hot decision-making situations with ICU research and that type of thing. Thinking about where you're consenting them, so doing public health, doing community-based research. Do you have, are you sort of interviewing them in a place where there's lots of distraction, even if they're physically away from it, you can't hear them, they can sort of see stuff, or do you have like sort of a little room or cubby off to the side where you can sort of calm things down and do your research procedures with the young person or the consent? So I think a piece of it is more like a common sense type of thing. I don't know that there's a specific litmus test. The idea of hot and cold comes from like a variety of different types of situations.